Welcome today's speaker, Dr. Sachin Jain. And to introduce Dr. Jain, I'd like to turn the screen over to my colleague, Dr. Jared Conley, who's both an attending in the MGH Emergency Department and more importantly, the Associate Director of the Healthcare Transformation Lab. So Jared.
Excellent. Thank you, Eric. It's such a privilege to be with you all today, and we're particularly excited to have Sachin. I believe he's back in Cali in the LA area, so no longer in the Boston area, but it's great to be with you all today, and I think we'll have a very engaging conversation. So as a quick introduction, I think many of you know Sachin Jain, and I've been following him for years, but he is the president and CEO of the SCAN Group currently. He's charged with leading the organization's growth, diversification, and efforts to reduce healthcare disparities. He was previously president and CEO of CareMore and Aspire Health. He pioneered a variety of programs there, and even before that, including one focused on social isolation. He's an adjunct professor of medicine at the Stanford University School of Medicine and a regular contributor at Forbes. And prior to joining CareMore, he was the Chief Medical Information and Innovation Officer at Merck. During that time, he served as an attending physician at the Boston VA and as faculty at Harvard Medical School and Harvard Business School. He also did a little stint in government where he had a leadership role in the U.S. Department of Health and Human Services and was the senior advisor to the administration of CMS. So Sachin, it's great to have you. Let's start out, in 2019, you were awarded the most tech-savvy doctor in the U.S., quite the title. I'm actually, frankly, quite jealous. But what are some exciting trends in digital health that have got your attention recently?
Well, it was interesting to win that. First of all, I just want to say thank you for having me here, and thanks for hosting this conversation. And especially want to express some gratitude for Bob Novelline. He wrote a textbook of radiology that I think was kind of in wide use when I was a medical student. So it's nice to be here and kind of a full circle story. I was actually pretty shocked to win that because I would say my posture towards technology and digital health has been, I would say many would probably describe me as kind of a wet blanket on those arenas, in the sense that I think a lot of companies have been created with the promise of digital health without necessarily thinking as hard about what actually makes good healthcare, great healthcare. And I think there's been an orientation towards just believing everything digital is better without necessarily kind of breaking down into its component parts, the things that really make healthcare work for patients, most specifically interconnectivity and communication across the group of clinicians who are truly taking care of complex and difficult to manage patients. And so I would just say it was super surprising. As far as kind of trends, I would say the things that I'm most excited about within digital health are the things that make the boring stuff simpler and easier for people. So when people think about digital health, they usually think about, I think, single vertical clinical offerings on cell phones that are focused on men's health or diabetes management, or pick your favorite kind of undermanaged disease. I think that's what most people think about as kind of the most exciting things in digital health. My view is that it's the boring stuff. It's the provider experience things. It's the utilization management, the prior authorization technologies, all kind of oriented around making care simpler for patients, but that don't necessarily show up in front of patients. I mean, I think we've created a web of complicated systems that don't necessarily serve patients and clinicians super well. And so anything that simplifies the experience of clinicians is what gets me excited.
Yeah, I love that. I think certainly at HTL, we've always been hyper-focused on kind of the frontline clinician and what their needs are. And I think that very much speaks to that. I'm curious, could you speak also about the challenges that you're seeing as you try and move towards the digital transformation of care? What are the challenges in digital health that are maybe underemphasized but important?
Well, I think the biggest challenge in digital health is really the organizational behavior of healthcare organizations. And I think what you saw over the last 2.5 years during the pandemic was that things that people previously said would take 5 to 10 to 15 to 20 years to implement were kind of implemented overnight. And so it woke a lot of us up to the reality that change in healthcare doesn't necessarily need to be slow, plodding, and incremental, that it could actually, kind of take place if there was a decisive, force that actually, made those things happen. And so I think, the biggest obstacle to getting digital health into real practice, frankly, is ourselves. It's how healthcare organizations operate. And any one of you who's tried to make, the MGH or some other healthcare institution better know exactly what I'm talking about. You have an idea, you go to the person you think is responsible for kind of implementing that idea, and that person sends you to talk to someone else, who sends you to talk to someone else, who sends you to talk to someone else. And then 3 years later, you're still presenting your idea to committees and you're doing small pilots. And there's really what no one tells you at the outset is that there's no real path to getting broad adoption and implementation of something that's really well worn or really clearly laid out. And so that's why I think, digital transformation has been as difficult as it has been, despite the fact that the technologies that we're talking about have been around now for more than a couple of decades. It's the fact that, I think we have organizations that are set up to be conservative in their orientation. Some people would say that conservatism is actually a feature, not a bug, meaning, if these organizations were able to change really quickly, we might introduce patient harm. But I think that that's a glass half full view of the world, in that I think we already are introducing a lot of patient harm. When it takes a patient, 8 weeks or frankly, a lot of heroic activity on behalf of their clinicians to actually make the right things happen, that's a problem, but we don't necessarily see it as such. And so I think that, to go back to your original question, the main issue that is getting in the way of us implementing digital tools and technologies in care is really, the organizational behavior.
Yeah, I love that. And I know that certainly our new CIDO, Jane Moran, has been organizing to that end to really provide that organizational structure that might enable more thoughtful and quick, as you mentioned, transformation.
Let me pull on that for a second. So,
Sure.
Lots of organizations will set up digital shops or innovation shops, and that's a problem. I mean, meaning, I think it's a Band-Aid on the fact that we should all be thinking, the fact that we talk about digital as a vertical as opposed to just what we do in 2022 is a huge problem for our industry. Saying nothing about Jamie, of course, and I don't even know him or her. Saying nothing about Jamie, the fact that organizations feel like the way to solve this problem is by setting up a shop and appointing a leader and building a set of process, in my view, is part of the problem.
Yeah, certainly. And I think it's Jane, it's a female, but certainly the idea of embedding digital into the overarching care vertical rather than making it another silo, I think that's spot on. All right, excellent. So again, we're talking about digital health and care transformation here. These are top of the line items for HTL and certainly for many of us across the country. But you've been busy the last few years leading a variety of efforts in care transformation, either at CareMore or now at your time at SCAN. Could you speak about some of those efforts that really excite you and you'd like to see grow and spread?
Yeah, I mean, SCAN is, just to introduce folks to SCAN, which is not particularly well known on the East Coast. We're originally founded as the Senior Care Action Network. We're a 45-year-old organization that was founded by community activists. We're a nonprofit. And our founders were called the 12 Angry Seniors. These were people who really wanted to challenge the broken status quo of aging in 1977 and really wanted to age in place. They wanted to grow old in their homes, in their community, and didn't feel like the community was really well set up to do that. And so they founded what was then called the Senior Care Action Network, which now has this kind of radiology sounding acronym SCAN. And so we originally were part of what was called the Social HMO Demonstration Project, which was a project that the Healthcare Financing Administration implemented in the 80s to evaluate how the social determinants of health could be incorporated into healthcare to improve patient outcomes, and then subsequently transitioned to become a Medicare Advantage plan, which is, of course, the private program that's focused on, providing health insurance to older Americans. Today, when I inherited the organization, we had 220,000 Medicare beneficiaries in California. Today, we've expanded our operations to Arizona and Nevada and Texas. We serve over 270,000 patients. We have about $4 billion in revenues. We've also, to the point of your question, diversified to have 4 new care delivery divisions. So Welcome Health is our home-based geriatrics practice. Lots of companies are popping up in the older adult space, but very few of them actually leverage, the science and insights that are garnered from geriatrics as an academic discipline. And so we're trying to do that through the Welcome Health chassis. We have a company called Home-Based Health, which provides palliative care and chronic disease management for older adults. And then we have My Place Health, which is our PACE company. PACE is the program of all-inclusive care for the elderly, which merges healthcare with adult daycare to try to produce better outcomes for patients and keep them aging in place. And then, probably the thing I'm most excited about that was inspired by my time as a student and trainee in Boston is actually Healthcare in Action. I saw that Jim O'Connell is in the audience. Jim's been a longtime inspiration of mine. We started a street-based medicine practice that leverages the principles of managed care to try to take a total cost of care view of the management of people experiencing homelessness. And one of the kind of observations is that we as a society have no problem with emergency room visits and inpatient stays and ICU stays for people experiencing homelessness, but we're not necessarily adequately funding intensive primary care and behavioral health for people on the streets. In Los Angeles County, we have over 60,000 people experiencing homelessness on any given night. And so what we're doing through our Healthcare in Action chassis is actually, taking risk on the management of people experiencing homelessness, and then using dollars that would ordinarily go to ER visits, ICU stays, and inpatient stays, and applying it to deliver intensive primary care and behavioral health management for homeless older adults and others. So that's the full portfolio of things that are going on right now.
Yeah, I love that. Particularly interested, I think, as you kind of leverage your skill set and expertise as a system, and certainly you individually, to help the least of these, right? The people experiencing homelessness, as you mentioned. I know you've written about that as well. Could you tell the audience a little bit more about what has been your experience now doing this, right? Is this actually a feasible model in kind of the managed care world, and should others be adopting that?
Well, I think it's early days. We're I would say 11 months into the experiment. We have about 600 patients for whom we are the primary care group. I think there's incredible demand for these types of services. We've gotten outreach from San Mateo County, San Diego County, the city of West Hollywood about how do we get this model into our communities, because they recognize that in many ways the problem of homelessness has been miscast in society. In the West Coast, we typically think of it as a housing supply issue, which and I truly believe that how you define a problem influences how you solve a problem. And so if you call homelessness a housing supply problem, the solution becomes housing. But our view is that homelessness is in part a housing supply problem, but it is also a healthcare problem, because we all know that homelessness is caused by healthcare issues, untreated behavioral health conditions, as well as addiction, or untreated or undermanaged chronic diseases, and it is certainly exacerbated by undermanaged or untreated chronic diseases. And so any solution to homelessness has to have a healthcare component to it. And we just feel like that's largely been missing from the dialogue, and we're filling kind of an important space there. We've been talking a lot about what are the outcomes that we're going to represent for this group, and what is going to be the kind of measure of success. And we've actually, in a world where many healthcare groups measure their performance with hundreds of different measures, we've actually decided that we're going to have one, which is after an episode of care with our group, is the person housed or not? that's the only thing we're going to measure. I think that is the ultimate outcome measure for people experiencing homelessness. Now, some people would argue, there's a natural rate of people who don't want to be housed, and that's absolutely the case. So even if we were perfect, that quality metric would not be 100%. It would be some lower number than that. That said, I think that is the ultimate aspiration for people experiencing homelessness, is to get them into a place where they can be reasonably housed, either independently or, back to a situation where they've got this social connectivity or capital with people, that they know from their life, to be able to not be living on the streets.
Yeah, I love that. I love how you talk about really defining the issue at hand, and that helping with the design of the program. Excellent. Well, we'll continue to watch your progress in that regard. And I think, I know you've been collaborating with Boston Healthcare for the Homeless over the years, and we look forward to seeing what synergy might develop, and such great opportunities to help our persons experiencing homelessness. So you always like to not shy from controversy, which I think we all appreciate, as you write in your Forbes articles. One of late, as we think about care transformation, it's hard to not think about big tech having some sort of impetus and opportunity here. And you wrote in there, it's time for tech companies to get serious about changing American healthcare. They need to show us the art of the possible by changing healthcare from within, not as customers, but as owners. And the way they do that is by acquiring a large health system and integrating advanced tech-driven health solutions with solid risk management operations. Very bold. I'd love for you to speak a little bit more about that. Are you getting any uptake on interest? And how would this look like if Amazon, Google, et cetera, Apple might actually go in and buy, let's say, Mass General Brigham?
Yeah, well, let's take a big step back. I mean, I've been around this now for more than 20 years, where there's some big tech person decides that healthcare is broken, and they've made billions of dollars selling computers, and then all of a sudden, or building AOL, and suddenly they've decided that they want to now kind of focus on what they think of as one of America's biggest problems. They're going to focus on healthcare. And the way they're going to do that is they're going to bring people who've never thought about healthcare, to bring innovative tools and technologies and approaches, and then they're going to start a new company, and everything's going to be better. I've seen this movie play out now several times. The first one was Revolution Health, which was a healthcare company founded by Steve Case when I was in business school in 2006. The most recent example of this was, three unknown folks named, Bezos and Buffett and Diamond, who got together to, create Haven. There's kind of been this, perpetual fetishization of healthcare as the new playground for kind of folks from outside of healthcare. And now you see, kind of the same thing playing out with Apple and with Amazon and with Google, which have all had healthcare initiatives now for a number of years, to really mixed or minimal effect, to be super clear. And I think that they view healthcare primarily as a vertical into which they can sell devices. And that's, for a very clear reason. When you sell a device at a 20 or 30% margin, you're just trying to unlock markets, and so you're building new features, functionalities, and products to be able to kind of attack those markets. And it's just an extension of your existing business model. Healthcare organizations, when they're really, really profitable, their margins are in the 5 to 10% range, outside of therapeutics, I should say. And then, most of the time it's, 1 to 2%. So, so there's a reason that all of these organizations have initially start out with like lots of enthusiasm around health. And then they say, if I've got $100 million of capital to deploy, do I want to put it into something that's going to pay me, $1 million or $2 million a year? Or do I want to put it into something that's going to pay me $30 or $40 million a year? And of course, the answer is always going to be the latter and not the former. And so, that's why you've seen all these kind of starts and stops. When you see pharma companies getting into digital, when you see, big tech companies getting into healthcare services, it never really gets going. And so you saw Apple, for years saying, oh, we're going to have a clinic platform. Nothing's really come of that. Amazon, launched Amazon Care and then got out of it. Now they're kind of retrenched, and they've bought, One Medical, Iora, and we'll see, what comes of that. I think one of the biggest challenges of tech companies owning healthcare is that the businesses are just much messier. You're not selling a bunch of widgets. The way I describe it is that you literally have tens of thousands of SKUs in healthcare. The Mass General literally delivers like tens of thousands of SKUs. You've got uncomplicated diabetes, you've got diabetes with retinopathy and nephropathy, you've got diabetes with nephropathy, retinopathy, and neuropathy. I mean, you've got SKU after SKU after SKU after SKU. So when we talk about standardized process in healthcare, which is a lot of what tech is based around, it's very hard when most of the care we deliver in healthcare is ultra bespoke. And so I don't know that tech companies know how to manage that level of complexity. Now, of course, they'll say, well, the way we manage that complexity is through AI and through digital. And I would say, of course, those are going to be adjuncts, but there's a different, things get really confused when there's human emotion and, kind of real issues, that kind of complex human issues that come up, where it's not just about like, was the cancer appropriately diagnosed and was the patient appropriately triaged, which is how you would simplify it. But actually, did the patient feel comforted and supported when you actually delivered that diagnosis? And that requires that you actually have a real human capital strategy that's oriented around like hiring and supporting super compassionate workforces. That's not what tech companies do. And so it's just a really, really different business. And so I don't think it's surprising that these companies have failed. And I think it's not surprising that they're all kind of mildly wading into this thing. I mean, I think Amazon buying One Medical, Iora was probably, kind of my prediction coming true, so to speak. But I think that, what would get really interesting is if like, Apple or Amazon were able to, kind of get into a long-term partnership with MGB and say, what would it take to Amazonify or Appleify the entire patient experience within this health system? That would be interesting. But I suspect the reason they haven't entered into an agreement like that is because it's a lot harder to do than it looks. Going back to the point I made earlier about organizational behavior and what it actually takes to change these systems, that's that is I think the reason that this hasn't happened and probably won't happen for some time.
Yeah, love that. I think so insightful to just kind of break that down in terms of what we've seen. I mean, obviously, I think we've all benefited as clinicians with the Apple Watch, right? Certainly, that's been, as an emergency doc, right? I can quickly see if when someone went into AFib or how long their rates have been, in the 130s. So it's certainly some great benefit that we've seen, but I think you're right. There's a real opportunity, and who knows if they'll actually go that deep in. Let's switch a little bit to value-based care. And I think you have a mixed feelings about value-based care, as I think some of us do. That certainly feels like, some of the pulse of care transformation of late, and certainly the last several years, and it certainly is the darling has been, I'd say, for the last decade. You've been recently advocating for kind of a more leveled approach. In fact, you state one of the central challenges of value-based care is managing costs and quality while ensuring patients have a positive experience. Could you speak a little bit more on that?
Yeah, so just to give you a little bit of my personal history on this, when I was a business school student at HBS, I was, Michael Porter's first, research associate, kind of post-publication of his and Elizabeth Teisberg's book, Redefining Healthcare, which kind of popularized, I don't think they invented it, but it popularized the notion of value, equaling quality over cost. They introduced a lot of, I think, very helpful concepts in that book. What I would say, has transpired in the years since is that we've seen, kind of tremendous amount of policy innovation to enable value-based care. You've seen the introduction of ACOs, Medicare Advantage, is a fully risk-based, platform, and if practiced in its purest form, you've seen bundled payments initiatives. But I think, what has happened is that there's been a number of distortions that are introduced into the execution of value-based care. If the way you increase value is to either increase quality or reduce costs. You can either improve value by improving quality or reducing costs, or both. And I think a lot of folks, focus a lot on the cost side of the equation and not necessarily on the quality side of the equation. So I think you've seen, one of the key fundamental existential questions that I'm struggling with is 20 years into trying to make healthcare better, everything seems to be getting worse. Like, what are we doing wrong? I think quality, the cost piece is an important part of it, and the emphasis on cutting costs without necessarily enhancing quality. The other thing is that there's a statement about value-based care that everyone's afraid to make, which is, if I'm really trying to reduce costs, it needs to come out of somewhere. And I think, what people fail to acknowledge is, where is that cost going to come out of? And it either comes out of people's salaries, it comes out of fewer jobs, it comes out of smaller hospitals, it comes out of fewer diagnostic tests. And it also, what it means, and what most people mean by value-based care is, pay me the same amount and I'll do less for it. They're not saying pay me less and I'll do less, which is how we lower total healthcare costs. But what they're saying is pay me the same amount and I will do less for it. And then when you think about, you mentioned this kind of the frontline perspective on value-based care. What we've done is we've created an administrative apparatus that just annoys the heck out of frontline clinicians. It's like, do you really need to do this test? Do you really want to admit this person to this hospital? Do they really need to be at the Mass General, or can they be at the Newton Wellesley or the Faulkner, which is going to be lower cost for this condition or that condition? And so, the true measure, so California has kind of been doing value-based care for 3 decades. So I kind of walked into what I would say is the future that many people imagine. And what value-based care really looks like in its best form is fewer people needing, acute care. The single most expensive line item in the kind of healthcare global budget is inpatient hospitalizations. So if you can kind of reduce those, that's the thing that you want to do. But what a lot of people do on the margins of trying to squeeze pennies out of rocks is they will sometimes take patients who belong in hospitals and admit them in SNFs. Sometimes take people who do need higher level of care and deny them that care. And so the point is that there's a toxic positivity around value-based care. You can't go to a healthcare conference where someone somewhere is saying, oh, value-based care is the solution to the answer. We want to be paid on value, not on volume. There's young health services researchers everywhere who are trying to pin their careers to, I'm going to make value-based care come to life, not necessarily recognizing, kind of the unintended consequences that can come from the world that we're imagining. And so I've come to believe that the solution to all of this isn't going to be, better payment models. I think it's going to be part of the solution, but we also just need to have better leadership of healthcare organizations. That's kind of like, I think, the missing component. When I was starting on my journey of trying to make healthcare better, I always thought better healthcare policy was going to fix everything. And then as I kind of, started, dived into my business career, I thought, okay, better organizations and better organizational management is going to make things better. I now believe it's really, we don't have the leaders we need. This is a controversial statement to say to, the Mass General Brigham, but what would it take to shrink the inpatient footprint of the Mass General Brigham by 40%? Well, what it would take is a real commitment to making the population of Boston and surrounding areas, much healthier. And that's how you can actually lower healthcare costs. But I think I just read that you all are starting a new sophisticated tower, construction of a new sophisticated tower on the MGH campus, which is wonderful. We need tertiary and quaternary centers. But I think my point is that there needs to be an honest conversation about what it's going to take to reduce healthcare costs in this country. And it means that somebody's going to have to profit less. Somebody's going to have less revenue. And I haven't heard anybody in a value-based care talk say who that person is going to be.
Yeah.
Who that person or organization is going to be. Yeah.
Sure. I love that. I think controversial as ever. I think there's a real opportunity. I mean, certainly, of note, our new hospital is, I think, if I understand it correctly, is not actually adding new beds. It's more moving us to single occupancy rooms. although certainly that is a cost to be thought about. We are certainly grappling with capacity, as I think most hospitals are around the country. Certainly as we think about inpatient costs being number one, as you mentioned. And so we're doing a lot of work in the hospital home space, the home hospital space, to create virtual hospitals, which do have good evidence. I think that's actually one of the few models I know of from a health services research perspective that does hit on the quadruple aim. And
except for the fact, Jared, that every hospital at home company wants to be paid exactly the same amount, despite providing less for a DRG, except for a lower level of service. So, and I will tell you, we talked about toxic positivity around value-based care. There's also toxic positivity around home-based care, in the sense that, people are kind of just believe it's better if we can kind of provide more care at the home. And it certainly is better, but in many ways. But here's what I'll say about it. What we're doing is we're taking work that was ordinarily performed by nurses and phlebotomists and doctors in the hospital, and we're putting it onto families and caregivers in the home. And I saw this, firsthand when my dad was started on peritoneal dialysis, during the pandemic. And I saw how much work we had to do as a family to kind of support him on dialysis. And that was all work that if he was going to a center was done by staffing that was paid for by, his dialysis company. And so I think we just need to keep ourselves honest as we talk about these models. And if we say, oh, we're going to move lots of inpatient stays to the home, it's great for the patients. Let's also just make sure, but by the way, I'm not using the bed anymore, but pay me the same amount, the exact same DRG, but I'm not going to staff it as richly as I did. That's an important conversation that isn't happening around this.
Yeah, well, I think you open up some honest conversations that I would say I'm pretty heavily invested in this space. I would say that there's plenty of individuals that are seeking lower payment, but not necessarily, again, a lot of that has not been worked out yet. Certainly it hasn't with the CMS waiver as of yet.
So I want David Levine, who, I know who runs the Brigham's program on this. I want him to go to Niyam Gandhi and say, Niyam, who's the CFO at MGB, Niyam, I want to make sure we get paid less for these DRGs. And I just want to see how that conversation plays out. I mean, that's, so there's plenty of individuals who want to do the right thing. But my point is at the end of the day, there is this kind of no margin, no mission ethos that kind of really biases towards the margin part, that I think we need to kind of just confront head on. And I think David does amazing work, and Niyam's a good friend and is a spectacular CFO. But being a spectacular CFO doesn't mean, going to your payers and saying, hey, I'm going to do hospital at home, pay me 40 cents on the dollar, which is probably along the lines of what it should be.
Yeah. No, very, very interesting and hard questions. I think certainly the evidence is there that we could get paid less to do that care. And I think it will, behoove the ongoing conversation between payers and health systems and hospitals and frankly, others to think through how do we do this creatively in a way that, again, the evidence is there that this is a model that we should be pursuing. It doesn't mean, to your point, that the margin is going to decrease unless it's done very thoughtfully, correct?
Absolutely. I mean, what I'll say is that, my experience of health services research, and I started out my career thinking that that's what I was going to do, is that we know plenty of ways to reduce costs. I mean, there's untold number of studies where we've kind of demonstrated better quality and lower cost. But there's a translation gap between, the study that's performed, in a unit at a hospital or within a clinic, within a system, and then, the scale question. And I think the best example of this was, Duke's efforts to reduce, to improve the care of heart failure patients in the 90s, where they were able to build an outpatient intensive heart failure clinic that diuresed patients on an outpatient basis, got them out of the hospital, and was so material that at some point the CFO calls, the head of that heart failure clinic and says, what are you doing? You're emptying the hospital. You're costing us, a significant amount of money. So that's where kind of care transformation butts up against the reality of organizational finance. And that's where I say that goes back to this whole leadership issue, is that if we're really nonprofit organizations, and we're really focused on, kind of trying to improve care and serving the community, then at some point we need to cannibalize our own business. At some point we need to shrink, not grow. At some point we need to get paid less, not more. And I don't think we have enough of those conversations within within the boardrooms that I've sat in, because everyone's saying, oh, we want healthcare costs to be lower, but we want our top line to be bigger. And that's just that's kind of an incompatible statement if you're being really authentic.
Yeah, I love that. It actually makes me think about Jim Weinstein's piece in the New England Journal about, I don't know, I think it was about 2008, 2009, 2010, around the cost saving illusion, right? That you can actually do all this work to try and improve care, but because of the fixed costs of healthcare, it's really hard to make those a reality. So, well, that's helpful. Very great discussion on that. Let's talk a little bit about, you actually hit a couple of the topics I wanted to talk about, leadership, no margin, no mission. Let's talk a little bit more about what is often referred to as kind of top of license care. It's hard to think about care transformation, but without talk about, you talk about it as like the great labor arbitrage in healthcare. In fact, I love this quote that you put in Forbes. You said patient care is being moved around to individuals with different levels of professional training without any clearly defined architecture delineating where and how patients are best served other than cost. What do you think is the best path forward here? This is a very challenging topic. I'd love to get your thoughts.
Well, I'm maybe I'm biased by my own experience, but I'm super clear-eyed on this. And it's that we just need to get out of this view of medical practice as, independent practice. So, every professional line in healthcare, these days is, argues for some, version of unsupervised independence. You see this with, state regulations around advanced practice professionals, nurse practitioners, PAs, pharmacists looking for individual prescribing capabilities. Every professional line thinks it should be operating independently. And I think independence is not a virtue in healthcare. Healthcare is best practiced as a team-based sport. And, to unpack, what I was talking about in that column a little bit more, just for the listening audience, every healthcare company in the country right now is involved in some version of trying to execute labor arbitrage, meaning, work that was performed by specialists should now be performed by generalists. If you're a generalist physician, then it should be performed by an NP or a PA. If you're an NP or a PA, it should be performed by an RN. If you're an RN, it should be performed by a medical assistant. If you're a medical assistant, it should be performed by a community health worker or a layperson. And it's some version of like all of those training qualifications are exactly the same. And when I was at CareMore, I led a program that was focused on ESRD patients, and I had a nephrologist who I recruited to run the program. And she said to me, it's kind of weird. We take the sickest patients in the healthcare system and we panel them to fresh nurse practitioners graduates, and we expect outcomes to be better. Does that make any sense to you? And it got me thinking about this notion of, how do we get people thinking outside of like, practicing independently and practicing more like we were trained in residency, which is, the medical student was supervised by the intern was supervised by the resident was supervised by the attending was supervised by a chief, the chief was supervised by a chair, and so on and so forth, to ensure that there is, in some ways like a Swiss cheese model of making sure we're being super complete in our thinking. And that's how you effectively leverage, people of different training. What I'm not suggesting is that, we should take, road administrative work and make physicians do it, which is how my comments sometimes get interpreted. But what I am saying is that in kind of poorly designed clinical models, and most are poorly designed clinical models, the role of the physician in this kind of pyramid scheme of labor becomes chart audit. It's like they review the chart and they say, oh, was this a complete note or not? And, for this kind of patient encounter. But that is a very incomplete form of quality assessment, because if you're not laying eyes on the patient yourself, you're not actually asking a different set of questions, you're not close to your patient, you're not close to your work. And so as a result, you don't know if there was an important question that wasn't asked. And I think that's something that this is, when people get mad about business people getting involved in healthcare, I think this is one of the things that they probably get most mad about, which is the vast oversimplification of complex clinical conditions into, algorithmic care that can be delivered by the lowest cost professional, when in fact, all of us who've taken care of patients know that, abdominal pain is not abdominal pain. It's 20 different things until you kind of look at the complex set of data that, kind of surrounds the chief complaint. And what I would say happens as you get, kind of into higher and higher degrees of training across the professional disciplines is just a greater appreciation of that complexity and a greater appreciation for the diversity of presentations. And, frankly, experienced attendings get things wrong all the time. So why do we expect, kind of, fresh graduates from, APP programs to get it right all the time? And again, these questions just don't get asked as often as they should or as much as they should, because it kind of is orthogonal to the business interests of a lot of, healthcare businesses that want to convince you that a community health worker can solve all problems. And it's just not the case. There is a role for all of these different, players on a healthcare team. I want to make sure I say that affirmatively and very positively. But I think what we do is we do a lot of people a disservice, which is we put them into situations that they're poorly able to manage, and expect them to practice independently. And I just have seen so many bad outcomes and so many things go wrong because there isn't that extra pair of eyes. And again, this is not to disparage any single professional discipline. It's just to say that the delivery of care is complex. And I think so much of what business forces have done is tried to simplify it and make us think that, MD equals NP equals RN equals, medical assistant equals community health worker. And all of us who've kind of invested the time to learn these arts know that it's not that simple.
Yeah, I love that. I think it's such a refreshing viewpoint on a really challenging topic that people have a lot of inherent thinking about, and perhaps bias, just depending on what their degree might be. Well, in the interest of time, I'm going to give an opportunity for others to ask a few questions. I still have a number that I'd love to ask you, but go ahead and submit your questions into the Q&A. We do have a couple to start with, and I don't know if Eric had any as well he wanted to kick off with.
Thanks, Jared. Just a couple of quick questions to add on to the discussion we've had already. It's interesting. There are so many competing forces that every time you look to try to do something, you can see the counter force that's going to keep you from succeeding. But if we get down to a more granular level, we have this constant tension between what a doctor is expected or hoped to do during a visit or encounter and what's realistic given the amount of time. And generally speaking, it's almost impossible to really give the patient or the problem your full attention or the full time because you could turn a 15-minute visit into an hour. So it ends up being more efficient for the provider to simply call a consult or order a test. And a test costs a whole lot more than an extra half hour in the office with the patient, but the way we have the payment system set up, it's not worth it. And as a cardiologist, I see patients who have 4 different cardiologists for each of their problems because it would take you much too long to address all of them. So you divide it up and the health system pays for 4 visits rather than 1. But with this constant tension, it's never worth it to provide the patient all of the attention that he or she deserves. It seems like we're stuck in this vicious cycle where we drive up costs, but we don't improve quality. And I don't know how we get out of that, but I just was wondering, in a tertiary center, that seems to be a big predicament.
Yeah, I mean, I would say, what I've seen out here is, the use of capitation, I think actually gets a real handle on that to some extent. I mean, I think what you see is in something, let's just take cardiology, for example, we will subcapitate cardiology to a group, which creates, a financial incentive for that group to really be thoughtful and careful about the use of those conditions. The hard part is really making sure that there are the appropriate guardrails against, underutilization or overutilization. I'll tell you a fun story about cardiology. When I was at CareMore, we subcapitated cardiology to a cardiology group. They managed cardiology spend really well, but they actually carved out EP procedures. And what we saw was that in a population of 9,000 patients under that agreement, there were more EP procedures than there were in a population of 60,000 patients in another group. So there was an overutilization of the thing that they were paid more for. And so I think it's one of those things where, the devil's in the detail about how these arrangements and contracts are negotiated. And then it's also, some degree of self-regulation. If you're paying people to manage a population, there's a strong incentive to manage a bigger population than you actually can. And then there's corners that are being, that end up being cut. And so, and no one's telling you that you can only capitate 2,000 patients or 10, and keeping you from capitating 10,000 patients. So these are the kinds of, I think, things we have to work through in the coming years.
So it seems that as long as we've got a fee-for-service model, at least half of it a fee-for-service model, we're perpetually going to be stuck and unable to move forward. Do you have any hope that we're going to move beyond this?
I think it's going to get worse before it gets better. I do think that there's going to be kind of a crush moment when we kind of start to look at. So I'm, in addition to being a health insurer, I'm also a purchaser of health insurance for my employees, and we don't have our own commercial health insurance product, so I have to go to the market the same way that any other employer would. And I'm a pretty sophisticated buyer. I work in the space. What I can tell you is that our healthcare costs, just based on our utilization with our 1,500 employees, went up $2.5 million, this year. So we went from a $13 million bid to a $15.5 million bid to, I was able to lock that in for 2 years. And, but the point is that there is going to be a moment at which this just becomes no longer viable, and it becomes, more viable to pay Obamacare penalties. And at that point, I think everyone starts to look at this and says, we have to do something completely different here. My greatest hope is that the large health systems will get smart and start to build their own startups that actually kind of disrupt their own business model. I think it's amazing that we have all these, kind of companies that have popped up on the side that have these great valuations that don't offer the full suite of things that, something like a Mass General Brigham does. But, at the end of the day, like, if you have a great primary care offering out on the side, but you don't have the specialties, or you don't have, all the ancillary services or the diagnostic capabilities, you're really not able to provide full service to patients. So large integrated delivery systems actually, I think, continue to have a role. The question is how do you create a leaner, more convenient experience for patients? And how do you disrupt yourself in the process? And I almost think someone like Neum should take, $100 million off the balance sheet of MGB, or maybe even $1 billion off the balance sheet of MGB. And rather than building a building, starts to just build a leaner version of itself, and start to think about, how do you actually, in a global risk environment, in a fully capitated environment, start to create incentives for someone like you, Eric, to spend an hour with the patient, and get everything done in one visit, as opposed to, spending 4 15-minute visits with 4 of your colleagues at 4 times the cost. So.
Thanks, Jared. I'll turn it back to you to take from the Q&A.
Excellent. I love that. In fact, there's a question that's related to that, which is around, are you a supporter of kind of ambulatory peer-to-peer asynchronous e-consults? Do you see this as a value added? And I would just add that I know you've written about the idea of the virtual care and redefining what the visit is, which I think also speaks to Eric's point. And really, you've written about, building the visit into more of a 2-week increment, and allowing us to do kind of all the care that's needed during that 2 weeks, and being paid for a 2-week kind of increment or episode of care, rather than this, every touch point, bill a service. But could you speak to that?
Yeah, I mean, I absolutely think, e-consults have a role. I think to answer the e-consults piece, I think e-consults may be, a way to kind of move beyond the kind of, to better leverage the APP workforce and, the generalist workforce.
Mm-hmm.
So if you're a primary care doctor who can then call Eric and say, Eric, I've got a patient in AFib. what are the things I need to do right now, according to current practice guidelines, that can obviate a visit, to a cardiologist if at me as a primary care doctor is able to call Eric. But because I'm not super confident, because I don't see 108, AFib cases a year, most of the time I would just send the patient to Eric. Now, what an e-consult model does is it kind of rewards Eric for work that he was doing for free previously, and potentially take some things out of the system, some cost out of the system in the form of a cardiology visit. But that really requires us to change our medical education paradigm, which right now is oriented around, hey, if the patient's got a cardiology issue, like let's call let's get a cardiology consult. People will hide behind medical legal reasons. Sometimes it's not really medical legal. Sometimes it's time-based, and sometimes it's expertise-based. And so again, I think we have to think about whether we want a system that's based around confident generalists. So I think that's who have access to the e-consults. And I'm forgetting the second part of your question, Jared.
No,
it was around the two week visit. Payment. Yeah, and again, I think people talk about things in stark terms between fee for service and kind of capitation, and then full global capitation, professional capitation, and then global capitation. I think there are potential interim steps to get us out of this, which is things like the thing that Sean Duffy and I proposed in that health affairs piece, around paying for a smaller episode of care as opposed to paying for total population health management. So that's another view of things.
Yeah, love that. Another question was, as one of the most visible health tech products, does the EMR's rollout over the past 2 decades offer a window into the pace of change, the impact ceiling, and the challenges of penetrating the health system with technology?
Well, I think the EMR, there's the EMR story is a complicated one, in that I think there was a huge regulatory miss, like day one of the HITECH Act, which was for those of you who are less familiar with the policy, was the federal act that was included in the 2009 Recovery Act that paid doctors and hospitals to implement electronic health record systems. And I happened to be, part of David Blumenthal's team when that was happening. And there was this question of how hard do you push on interoperability day one? And I think there was this, kind of reasonable at the time decision made to let's get everybody on the systems first, and then we can kind of require interoperability. And I actually think that was a big failure on some level. I think the interoperability should have been just required. And we sometimes treat interoperability like it's putting a man on the moon, like it's this big technical lift, when in fact, it's just really it's a political and organizational problem, not necessarily a technical problem. So I'm not sure that there are that many lessons to be learned from the EMR implementation, other than that it was done incorrectly for the country, with the stage 1 meaningful use regulation from 2009 and 2010.
Yeah, I love that point. Perhaps our last question, what would it take for tech to transform preventative healthcare?
I think thanks for the question, Felipe, and hi. Felipe and I were good friends in medical school and are still friends. I would say, tech is trying to play in the prevention space, but I think, again, it's trying to do so wrapped around the existing healthcare system as opposed to working with and integrated with. And I think that there's so many paradigms around wraparound, and having operated wraparound companies, they're really hard because you're seen as duplicative and potentially providing conflicting information to patients, and conflicting guidance. And so I think I really believe the next wave of health systems leaders, of large integrated delivery systems, their work is not going to be getting bigger, building more towers, growing their scale. Their work is going to be, the internal transformation, innovative partnerships with tech companies to really fundamentally change the operating chassis, the payment model, and then things like a focus on prevention. But I think that their ability to do so outside of or disconnected from people's primary and specialty care is misguided and unlikely to be effective.
Yeah, love that. Well, with that, we'll close. This has been a great and engaging conversation. We love how you're so interested in really pushing us as a health system, particularly our leaders and the frontline clinicians, all of us, to think really deeply about these issues, to think critically, and to really, again, have the patient at the center and that affordability question. So really appreciate your time, Sachin, and wish you the best of luck, and look forward to crossing paths and having you come back to Boston again soon.
Thanks so much. It was great to be with you all. Really appreciate it.
Thank you all for coming.
Thank
All
you
right,
all
thanks.
for
Thank you.
joining. Thank you, Sachin.
All right.
Yeah.
Okay, thanks a lot. Bye-bye.
Bye.